Once again, thank you to the organizations for this panel discussion. And now we have approached the final presentation of the day. It is titled Hormonal Guidelines and Blood Tests, What You Need to Know. And once again, we have Lina Mulera Santoro to give us this lecture. During this lecture, we will be hearing about specifics of medical monitoring, hormonal guidelines, reversible and irreversible physical changes, absolute contraindications, side effects, risk benefits, analytical controls, and expected values. Once again, this presentation will be happening in Spanish, and you have two options for interpretation. One of them is if you have your own headphones with you, you can use your phone and scan the QR code that you see on your table in order to access Transgénero Platform's website, where you will have live access to live translation. And then the other option is to use headphones like the ones that we headed out before. Those are set to channel 2, and channel 2 is the one where you will be hearing the live interpretation. Other people in the audience that do not have headphones, and we can give you new ones. We can hand out new headphones for that purpose. So like if you don't have headphones, raise your hand. Otherwise, we're all set, which would be meet.
Anyone in the back need headphones?
One. Okay, but I guess we're all set. And I will once again give the stage to Lina. So, Lina.
Gracias. Hola. Mira. Thank you. Bien, hola de nuevo, gracias. Bueno, hablaremos de pautas hormonales y riesgos, beneficios, cambios, pero antes me gustaría tomar 4 minutos de mi ponencia para un poco rescatar lo que he podido entender de
A little bit
la mesa anterior,
of what I understood
sobre
from
todo
the last discussion.
con la pregunta de Angélica, ¿no?
I stuck with Angelica's question: How did Catalonia? How was this change possible in Catalonia?
Y la respuesta es clara.
And the answer is very clear.
Hay que conquistar los
You have to
derechos en la calle.
conquer the rights on the streets out there.
Yo creo, desconozco cuál es el
I
marco
think,
legal
I mean,
sueco.
I don't know what is the legal frame in Sweden, but what I know is that the rights are not
Estoy
getting.
segura de que tiene que haber una ley sueca.
I'm sure there is a Swedish law of like anti-discrimination, LGBTQ or something like that. Some type of law that is against discrimination for identity, gender or sex reasons. We also have the resolutions from the European Parliament towards trans people and the treatment that they should receive from the healthcare centers. And then we also have the last publications from the standards of cares, SOC 8. Their SOC 8 has deleted dysphoria, gender dysphoria. So here, the rights are being vulnerated. The loss of anti-discrimination as well. What is happening in Swedish law is institutional discrimination. So for what I understand, what you have to do is to complain, to get out loud, be out loud, one voice. What I understood is that all of these organizations that are here today, you all agree that this system has to change. You all agree that we need respectful attention from the healthcare system. So let's start complaining and ask for this change. And if in Sweden they don't hear us, then we go to the parliament in Brussels and we demand it there. So nothing's going to change if we don't ask for it. We have to scream very, very loud that this is necessary. This change must be. Come on, let's do it. Okay. The goal, talking about hormonal guidelines, we understand that not all the people need a journey, a hormonal journey. Not all the people need hormonal guidelines to be able to be who they are and to live their identity fully. But for those who choose it, it's important to know what is behind these hormonal guidelines. And first of all, to understand that for the medical staff supporting health care for trans people, they don't look for these analysis or these doses that need to be adjusted. What is not searched is that it's an exact level. You want to do this transition, you need to be here. No, that's not what we're looking for. What we're looking for is to be well. Welfare. So what we know is that medically it would not be okay to provide guidelines that raise or increase the levels, analytical levels, beyond of what is expected in a cis person, so that we understand what we're saying. If I am some-minister testosterone, we will measure the optimal levels of any cis man in the age range where they are as normal. From here, we can be below this. We can choose to be up there or a little bit lower, but what we should not be is to be beyond this level, because this is where the problems can come, or the side effects can come. To say something is that genetic conditions a lot the physical changes than the hormone itself or the hormonal guidelines itself. So we have to look what predisposition we have to assimilate these changes. Not each body is different, and of course the changes are not going to be like uniform for everyone. And we also have to understand that if a person doesn't have their gender changed in the as a legal gender in their sanitary card, so the levels that they're gonna throw up there probably will be read as an error in a blood test, because they're being read from the gender sex, opposite gender sex. So we have to read it regarding of the guideline that we are using. Okay, we're gonna start talking about the masculinization preparations. We're talking about testosterone here. For people who want to modify their body with secondary characteristics understood as masculine, it's purely just testosterone. It's not necessary to apply a blocker of the hormone that they do produce, because testosterone is very strong, very powerful. So as soon as you administer testosterone, automatically the function of uterus and ovaries are getting like blocked or paused, and so testosterone starts doing its physical changes. It is commercialized two different types. Injectables on one side. Here we have possibility of injectable. In Spain it's called Textex. Probably here is something similar, but it's one injectable that you use every 2 or 3 weeks. And then we also have the every trimester, so around 4 to 14 weeks. Then we also have the topical gel, so it's with testosterone applied to the skin. Testogel, Testavan, Itnohan, these are commercial brands, but basically this is just testosterone in a gel form. Right. What can you expect in the blood test when you are administering testosterone? Talking about hemogram or like the blood test purely, we can find an increase of the hematocrit. It's an increase of the red blood cells and hemoglobin. We can also notice an increase of the cholesterol, the bad one, and a decrease of the good cholesterol. A possible increase of the hepatic enzymes. So that's why these medications, they are being told to say that if you have hepatic problems, then you have to be careful. Increase of creatinine and urea, and the filtering of. So it makes that the kidney functions in a more unnormal or less efficient way. Other parameters that can be increased is the blood sugar and So what are the effects that you can expect? Is a more oily skin, the redistribution of the mass, getting a more masculine shape, redistributing the fat to those parts where the patterns are understood as more masculine. The menstruation disappears, so there's also hypertrophy of the clitoris, so it becomes bigger. Also dryness, vaginal dryness, and also an increase of the muscular mass. The voice, there's also visible change. It becomes deeper and typically understood as masculine. Also hair, body hair and facial hair. Any content that you get symptoms of baldness, and we go back to genetics, because if in your family there is a predisposition to getting bald, then this is probably, or like it's easily that this could happen. In the first column we find the months that you can be for this to be expected, and the second column is expectation in years. Something else to highlight is from all of these physical changes, talking now about testosterone and then we'll talk about estrogens, most of them are reversible. Most of them, if we stop the process, they are getting reverted and they go back and go back to what they were before, except if the clitoris has been bigger, the facial hair, and the voice. So all of these are irreversible. Okay, first of all, I want to explain that these hormonal preparations, but it also happens with the testosterone blockers. All of these medicines are outside of technical data sheet. It means that the FDA has not approved this for the use that we are making of them. All of this medication that we are using was not created to make a gender transition. It was created for other goals. So it makes sense that when they say there's no scientific evidence, so when they say there's no studies for trans people with specific medicine, or how is that going to be if we don't have medicine that's being created for specifically trans people? So we're talking about medicine that's outside of technical data sheet. And all of these medicines, there's a practical medicine practice. This is not the only medical medicine that is outside of technical data. Like there's so many of them, especially in pediatric practices. There are many medicines, antidepressants that are outside of the technical data sheet. Maybe in conclusion, this is not weird or not normal to use medicine for something else to what initially was created for. What we have in testosterone, we have some contraindications that are absolute, where it's not recommended to use testosterone because you cannot use it. There's a big risk for the health if you have a presence of pregnancy or embolia or like heart minute. Cardiac, like if your heart could stop, also heart attack. There's also some risks that we'll have to consider if we want to assume them or not, depending on what we want, but so that we know that they exist and they can come up, they can appear. So here you evaluate the benefit, what is going to give you the use of this medication in opposition, or what you risk that could happen. So this, when we talk about self-determination, we talk about this. I understand this. We say I understand the risks. I assume them and I decide. With the use of testosterone, severe acne can happen, and also body acne. There can be risks if you have breast cancer and your family as well. If there is an increase of red blood cells, this is also a risk. If there is diabetes, if you're dependent for insulin, and also other ones for risk of thrombosis, or if you are using testosterone in combination of tobacco. Also talking about people obesity. when is a high level of triglycerides in the blood tests, or when we have arteries that are prone to arteriosclerosis. So if in our family we have a tendency of people who have gone through arteriosclerosis, so this is a risk factor. Also, if in your family there are signs or of heart or clotting diseases or liver disease. When we use testosterone, we increase all of these factors, and we have to decide if it's worth it. We also have secondary side effects. No. Yes, side effects. All of this is what I was saying that are outside of technical data, and we have to say that the long-term effects are unknown. Why? Because there's no studies. This is unknown for trans people, but it is known for cis people. So the studies have not been made for trans people, but they have been made. Testosterone have been used for cis people for very, very long time. When there's a gonadism, when there is a less increase, so less testosterone, or when there is some type of intersexuality, or when there is some type of anomaly, where this is used in all ages. There's a bunch of studies. When we say there are no studies, it's purely on trans people, but it's been used forever for cis people. The side effects that can come up, as all side effects of any medicine, some are very low, of a percentage very, very small. Only a few people of a study of 10,000 have some type of this symptom. Some are more relevant than others. The increase of thrombosis, arterial or in the veins, affecting the kidney, or an excess of red blood cells, more sweating. All of these are relative side effects. Increase of libido. This one is this is very effective. Testosterone increases libido. Skin eruptions. I don't know if you say that like that. Tachycardia or insomnia. This you can expect quite a lot. Or vaginal dryness or chronic pelvic pain. This is also something that is being discovered after using testosterone for the last 10 or 15 years. Many people present many pelvic pain similar to menstruation. They don't end up really having blood as in menstruation, but sometimes when they have sex or penetration, there can be this pain because the tissue, the vaginal tissue doesn't have estrogen anymore, and now the testosterone is running there, so it becomes a little atrophia, and that's why this pain can come. Recommendations could be to avoid toxic substances and have a good balanced diet, to rest and take care of your mental health. I mean, be an exemplar person. When we start hormones with testosterone, what is recommended is to have a blood test in the last year and make sure that there are no some values that are altered, to make sure that the blood sugar is okay, the cholesterol is fine, Normally, this is in general, so like in a blood test in general. If you're talking about a healthy person, then we can start this hormones with testosterone, and this will not be necessary to take another blood test after 3 or 4 months have passed. We talk about 3 or 4 months because here's when we say we have stable levels in the blood, and we can make a real measurement. The values that you can ask are these ones you find here: hemogram, complete hemogram. So what, in conclusion, what you have to ask in a blood test. So those factors that can be shown when you are using testosterone. We were talking about kidney, about the liver, and so on. So you have to ask for these values. If testosterone say that these values can be altered, then these are the values that you have to ask for. And then complete or full hemogram, and of course sexual hormones: TSH, FSH, LH, estradiol, testosterone. All of these are hormones, nothing else. When we use injectables, it's recommended that the blood test is at the end of the period. So if we're doing an injectable of 3 months, then you do it at the end of the 3 months, like 1 or 2 months before you're going to do the injectable. We always try to measure what's the lowest level in the blood, and from there you adjust the dose if it's too low or if it's too high. In the case of gel, if you're using gel, then what's recommended is to have the blood test not before 12 hours after you have administered it. If we talk now hormones or going for feminization, then we are not that lucky to use just one thing. So if we want to do a feminization in a short period, I mean, here short periods don't exist really, because we're talking about long periods. We're talking about 3 or 4 years. But if we want to make a feminization in that time, then we have to introduce estrogen, and we should, or we can also use a testosterone blocker. Estrogens by themselves can block testosterone, but it's gonna be very difficult. It will take a long time for the estrogen alone to delete the testosterone, producing testosterone. We're talking about many years. So normally what we talk here is to use estrogen so that introduces the changes desired, and also a testosterone blocker so that this doesn't be in opposition with the estrogen. The estrogens that are commercialized, at least in Spain, are 3 days, where you have like pills, patches, and the gels or sprays also. There are other parts in Europe where injectables are also commercialized. In Spain, this is not the case. I don't know if here in Sweden this is a thing, if it's available, but it's not very often this practice, because the injectable of estrogen doesn't come alone. It comes with other progesterones, and they're not completely recommended. For this type of transition, what is recommended is pure estrogen and natural. So estradiol valerate. There are others, but the risks get increased too much. So the use is not recommended for people who want to make a gender transition. The anti-conceptive pills and all of this, these are estrogens, but they increase so much, very, very much, the risk to get a cardiovascular disease. So it's really recommended to use estradiol valerate purely. Okay, so now desired or expected effects for people using estrogen. In cholesterol, it happens the other way around, as in testosterone. The good cholesterol would increase and the bad cholesterol would decrease. So in this case, there is a little protection. There can be an increase, a little alteration of the hepatic enzymes, and also there might be an increase of blood pressure in some cases. Something else that also increases normally is the prolactin. The prolactin is the hormone in charge of in a pregnancy, is the one in charge of preparing the mammary gland to produce milk to feed the baby. And this prolactin is usually shown to be increased in transition processes. Normally you can see it 2 or 3 more times more elevated. This is normal, but if there's more than this, then here's when you should control the prolactin. It's recommended to do a TAC or to make sure that you're not suffering of a cerebral or brain tumor. All right, here now this is estrogens. Now we go with androgens. The goal is to reduce the levels of testosterone in the body so that the estrogens can work better. Here, we in Catalonia, we commercialize, there's so many more, but we commercialize or we try to move into these 3: bicalutamide, spironolactone, and cyproterone, commonly known as Androcur. Bicalutamide, it's a blocker used for a very, very long time ago against prostate cancer. And we have many studies, safety studies, in very much higher doses than the one that we use normally. And what is new, or what is good about using this type of androgen is that it doesn't block the production of testosterone. Sorry, what? No, it does not block testosterone, the production. It blocks the receptors. I let you produce the testosterone, but I don't let you come in where I don't want. So not on my skin, not on my joints or bones, the mammal, the muscle. So of course it also affects less the genitals, the possibility of having erections if we want to have erections. So in this sense, well, it can be tempting for those people who don't have the genital dysphoria, that are using their genitalia in their sexual practices, that they want to continue giving and receiving pleasure, that they want to continue having libido and desire like this. So this is super good with this blocking, at least at the beginning of the transition, because as we said before, at the end, in a transition, in a very long transition for many years, the estrogens by themselves are also going to lower the testosterone. But at the beginning, in the first years, maybe we can get this feminization without the sexual function being altered. Then we also have spironolactone that is very known, and cyproteron. This reduces the it reduces the production of testosterone, but it doesn't eliminate them. And the cyproteron blocks the production absolutely. It blocks the gonads, and we even have a production of testosterone even lower of what is understood as feminine. So yeah, the consequences are that the estrogen is able to make their changes, their modifications, but we are sacrificing all of the part of the sexual desire and to be able to keep erections. The effects that you can expect in the use of estrogens and testosterone blockers: redistribution of the body fat, taking a more feminine shape, and those parts of the body that are understood as more feminine, so like the butt and the sides. There's also a decrease of the muscular mass. This is more of the estrogen, increase of estrogen, but not a decrease of testosterone. If the use of testosterone grows the muscle mass, then not using it or using estrogen up. We also get more softer skin, more like drier skin, decrease of spontaneous erections depending on the dose. First, it grows like the mammal. It's like a button. It's very hurtful. It's painful, and slowly, it's gonna give. It will be able to build the fat that goes around this the mammary gland. The decrease of testicular volume. This is also in relation to the use of androgens, spironolactone and androcur, cyproteron, not the bicalutamida. When there is no production of testosterone, then there is a decrease of the testicular volume, the sperm production, even with the treatment long term. So it can even stop with the seminal liquid, and ejaculation, as we understand, can disappear, and the testicles can even retreat, diminish their volume, and go back to their cavity hidden where they when they as it was when during the fetus, as in pregnancy, when you were in womb. Body hair reduction in the legs and the arms and so on, but not in facial. If there is facial hair, then it has to be removed with some type of technical measure. It can be. Many people ask us, will my voice change? Will I have a more feminine voice? No. Hormones don't, the feminine hormones, they don't change the voice. The voice, if you want to change it, there are some techniques. You can do logopedia or chirurgical intervention of the vocal cords. You can also train the voice, but don't expect change in the voice with the hormones, because this won't happen. With the use of testosterone, these are also medicine outside of technical data sheet, and there are some contraindications, absolute contraindications. You cannot take estrogens when there is breast cancer, venous thrombosis, or arterial thrombosis. Absolutely prohibited. And also we have some risks, benefits that you have to evaluate, depending on what we were saying before. If you have first degree, here it says breast cancer, but it's not only this, but also we're talking about hormonal dependent cancer. So we're talking about mammal, we're talking about uterus. If you have in your family, if this has happened, it is probably the case that a cancer like this can be that can happen. So if your mother has gone through this, then you have to value this. You also have to value the use of estrogen when you have insulin-dependent diabetes or when there are some risk factors, the same as in testosterone, the smoking, obesity, sedentary lifestyle, and triglycerides, or some arterial or heart disease, when there is some kidney failure. This is mainly the andro and when there is also migraine, a severe migraine. The same as with testosterone, the long terms with this are unknown, but there are some effects that can come up depending on genetics and also of the doses that could be used. Thrombosis, venous thrombose, gallbladder stones. We increase the possibilities of having breast cancer just the same as any cis woman using hormones, not more, just the same. And less frequent, we also have nausea, vomiting, fluid retention, especially at the beginning. After 3-4 months, it tends to regulate. And then we also have the increase of hyperprolactin, so that we can discard some diseases. Now we're going to talk about some anti-androgens, ciprofloxacin. The changes are a little bit slower. It has less effects for the erections and desire, but it has some contraindications when there is if you have increased potassium or a renal problem. If you have liver problems, I'm sorry, when you have adrenal gland, it's also not recommended. Or when you're also getting some treatment with hypertensive, like spleneuron, as side effects, it can decrease very much the blood pressure, some headaches, some nausea, but most importantly, no, I'm sorry, I didn't change the slide. The most important is that it increases that you want that you feel the need to go to the bathroom. So it's not recommended to use this at night. It's recommended that you use it at the beginning, in the morning, because otherwise you would not be sleeping and you would just be going to the bathroom all the time. And then lastly, we have bicalutamide, which was what I was saying before. The changes are very intense and quickly, similar to Undercool, but they also have some contraindications. If you use these two medicines, written here, an antihistamine and medicine for gastritis, so like digestive. This is the only thing that is a contraindication. You should not take this if you are taking these other medicines. The syndrome of QT large is an alteration with the heart, and you are born with this. It means that the heartbeats are not on the patterns expected. So there's an alteration of that heartbeats, what is expected for it. So the beta-glutamine is not recommended if you have this anomaly. It can also affect the liver, because it's a medicine that is hepatotoxic, so it can increase the enzymes, hepatic enzymes. To initiate the same as testosterone, to initiate a blood test in the last year, you have to be make sure that you are a healthy person, and after taking the hormones, you have like 3 or 4 months, you take this blood test, then 6, 9. If you have a stable, if you take hormones in a stable way, then you just need a blood test the same as any other person, cis person. Like how often you should take a blood test. Before taking the blood test, it's not recommended that you do exercise. When we do exercise, or we move, or we are agitated, the prolactin levels usually increase, and then the levels would be false levels in the blood test. So what it is recommended is to wake up 2 hours before the extraction, not do any type of effort or sport, go as relaxed as possible, and do these prolactin levels so that they are not altered. Right. Then the expected levels in the blood tests when using anti-androgens. The spironolactone can increase the potassium, reduction of testosterone levels, but not the beta-glutamate. Both in androcur and beta-glutamine may alter the liver enzymes. The follow-up recommendations is what I just said. It's the period every 3-6 months at the beginning, and then blood test. But after we are stable in our hormones, then you don't need to do this so often. You can do it like as in 9 or 12 months, as the rest of the people. Every time that there is a change of the hormones doses, or if you change anti-androgens, or if you change the brand of the estrogen, then we also do control with the blood tests until you have like a stable levels, and then we can go back to the yearly blood tests. We have to control the cardiovascular, and we also have to understand that the general goal is to get the physiological hormone values. Here, okay, what levels does my blood test should give me? Well, the gender that you feel, the felt gender. So the same as with testosterone. the recommended should be the range of the gender that you are transitioning to. What is not recommended as you are above these levels. If you don't want these levels to be so high, well, you can be below what a cis person would have. Yes, and thank you so much. Here I stop with all of this very complicated. I'm here to your disposal if you want to ask me anything. Thank you so much.